Welcome to Performance Around the Clock, where we explore the latest research on how to keep our body and mind at our peak physical, emotional, and intellectual performance around the clock. I am your host, Professor Satchin Panda at the Salk Institute, La Jolla, California. On this podcast, we'll talk to leading scientists, clinicians, coaches, and policymakers about human performance. We'll cover different topics, including how different organs and different parts of the brain contribute to human performance. And we'll also learn how our lifestyle, that is, what, when, and how much we eat, sleep, and move around every single day affect our health and wellness. I hope you'll join me in this journey to explore new knowledge and adapt it in our own life to improve our health and wellness throughout our life. Welcome to another episode of Performance Around the Clock. And this time I'm super excited to have Dr. Elizabeth Epstein from the Scripps Clinic just around the corner from Salk to be my guest. Dr. Epstein received her BA in Integrative Biology from UC Berkeley, and then she completed her MD, followed by internal medicine residency at University of California, San Diego. Currently, she is completing both a fellowship in cardiology at Scripps Clinic and a fellowship in integrative medicine at the Academy of Integrative Health and Medicine. She is super focused on partnering with, this is really interesting because when she says she doesn't treat patients, she partners with patients to improve their overall cardiovascular health. Welcome, Liz.
Thank you so much for having me. I'm excited.
Yeah, so tell me a little bit about how you got interested in cardiology and particularly this integrative approach, because when I see cardiologist, I always think of people who do surgery or rehab or prescribe medicine. But tell me a little bit.
Yeah, so I say I kind of followed the path unfolding. So I was at UC Berkeley and I took a class called Medical Ethnobotany by Tom Carlson there, where I learned about plants as medicine. He had traveled the world and gone, into the wilderness with these indigenous cultures around the world that have used these plants and herbs as medicine for thousands of years. And so that's kind of the background of the course. And I was so excited about the fact that things that you put into your body are medicine and it's very empowering. So that's where I got into this idea of being empowered to prevent and reverse disease on your own. And so got interested in that, ended up going into medicine and always had that interest, and found my niche in cardiology, where there's this amazing yin and yang of, we do have all that technology, we do have the procedures and the surgeries to really save lives. But the most powerful things we can do for our health are still belonging with the patient. It's their diet and exercise and overall lifestyle that are the most powerful aspects. So that was where I see myself in partnering with patients and helping them find the things that they can do for themselves rather than relying on the medical system.
Yeah. I mean, when you say plants as medicine, it actually, in many ways, it's true because I heard a statistics that more than 60% of all FDA-approved drugs can be traced back to some natural compounds. It can be from plants, can be from microbes, can be from marine algae, but they all come from nature. And when we think of food, natural food, just like you said, it's plants or herbs or sometimes marine products. Those are non-animal products. So yes, there is a lot of truth in that. And also, as you said, nutrition is another medicine.
Yeah.
So coming back to heart health, I always think heart health is the heart of our health.
I love that. All cardiologists will love that.
So that means you also agree with the idea that heart health is the heart of our health. Why is that? Why? I mean, when you think of health, we talk about brain health, gut health, liver health, skin health, and all that stuff. But what is interesting is, as I work with mice, and in mice, what you're finding is all these organs are kind of interconnected. Can you give me a little bit? Can you expand on this idea that heart health is at the heart of the health, our health, and how different aspects of our health, how brain or stress affects our heart health, how gut affects our heart health, how our blood sugar, for example. This will be, enlightening.
Yes, I do agree with you. I think all the organs are interconnected and interdependent in some way, but there is such a key importance and dependence on the heart and the lungs to get oxygen and deliver it to every part of the body and every other organ in the body in order for it to function well and in order for the person to be feeling well. We know in heart failure, when you start to get symptoms of heart failure, you can feel it in all different parts of your body because it's dependent on getting oxygen to the different tissues. So I do agree that that the heart is at the heart of health for all the other organs as well. And I also think that keeping a healthy heart and the things that you need to do to maintain a healthy heart maintain a healthy entire body as well. It's really that you're preventing these chronic diseases of lifestyle like diabetes, metabolic syndrome, and you are maintaining health of the arteries in the entire body. So I think that what you do for heart health expands to the entire body.
Yeah, but when we think about young people, say middle schoolers, high schoolers, college students, they are not worried about their heart failure or diabetes or any of this chronic disease. For them, what matters is, can they perform well in whatever sports they're enrolled in, or if they're engaged in, say, performance, dance, or any kind of activity. So, should they be worried about their heart health, or the heart is resilient enough?
As someone focused in prevention, I definitely think at any age it's good to start worrying about heart health. Even in young children, instilling heart healthy habits early in life and raising them in an environment that teaches those is really important. We know that obesity and diabetes are on the rise even in young children. So I think from a cardiometabolic standpoint, it's important early on. And then when we're talking about performance, as we move into adolescence, usually those large congenital defects that patients can be born with have been corrected in young age, but things like hypertrophic cardiomyopathy, congenital channelopathies like Brugada syndrome, anomalous origin of the coronary arteries can come to play and be responsible for sudden cardiac death, especially.
So those are quite a few mouthfuls. So can you break it down one by one?
Yes. So hypertrophic cardiomyopathy is the most common, and it just means that the heart muscle is abnormally thick. In certain areas, it can be in different formations, but it's abnormally thick, and it depolarizes abnormally, meaning the electrical signals are going through the tissue abnormally, and it can lead to dangerous arrhythmias.
Yeah, so what will be the symptom? The kids should feel palpitation,
Passing out, palpitations, and usually it would be passing out, or even worse, that's what could lead to VT or VTAC and cause someone to die suddenly. So it may not have a warning.
I see. Okay. And then you had a few other conditions.
Yes, anomalous origin of the coronary artery. So normally there's two sides of coronary arteries, the right and the left, and they come off the aorta. And one goes down the left side of the heart, one goes down the right side of the heart. There is a disease or congenital abnormality where one of them comes off the wrong place, and it can have a dangerous course where it goes in between the pulmonary artery and the aorta and be smashed there. So that can cause sudden loss of flow down one of the coronaries and can cause arrhythmias and major issues.
So that means kids who ever complain about any palpitation or pass out or low energy, or they're running and then feeling loss of breathlessness, the parents should be checking.
Yes. And we are starting to shift the mindset towards that every young kid, high schooler, especially athletes, should have an EKG and a questionnaire and screening. There's actually an organization here in San Diego, EP Save a Life, and their mission is to go and screen as many adolescents in San Diego County as possible. And so we're kind of changing our mindset on that, is that we really want to screen, and we do find quite a bit of quite a few abnormalities, and it ends up having kids end up getting an ICD placed to prevent any issues.
What is an ICD?
It is a defibrillator that goes just under the skin.
I see.
And if there's an arrhythmia, it will shock you and prevent any issues. That's the idea.
So you made a very strong statement that almost every high school or collegiate athlete should get an EKG and a thorough cardiac exam. I never hear from athletes that they do that, but this is something really interesting. So they can go through the university health program or the insurance to get it done?
They should be able to, and this is a nonprofit organization that every month or every other month they'll go to a different high school in the county, and any of the kids can come there for the screening.
Oh,
yeah.
And then you said quite a good percentage of kids turn out to have some abnormal condition that may prevent them from achieving their peak performance.
Exactly.
What percentage that can be? 1%, 2%, 5%?
I don't know the exact percent, but I know that I should have gotten that data on, what it's been in the last year, for example, but in every screening, there are quite a handful of patients that we find who need an echo or if something is found on the EKG that leads to further workup.
Okay. Yeah, so that's really interesting, because when we think of athletic performance or sending a kid for say ballet or dance or anything, because when you're thinking about sports, we always think about field sports, but dance is also a very physically intense exercise. So what you're suggesting is, now that I'm thinking about it, yes, almost every parents, when they're sending their kids for their swim lesson or swim competition or dance lesson, ballet or any kind of performance, they should, and that can help them.
It makes sense because, and this is the way I feel a lot about prevention, is that the risks are so high that we're up against, and the number who will get this, the number of patients who will end up with these conditions, it is rare, but the stakes are high, I should say.
Yeah.
And the risk of screening with an EKG is so low. There's no harm done.
Yeah.
And the risk of doing a questionnaire and asking if the patients had any symptoms is so low, and it doesn't cost anything. So it's kind of a no-brainer to do that, to try to find the small number but significant number who may have an issue down the line.
Yeah. And most of these are congenital. So that means they're born with this condition, but they may not have caught it. And now that they know that they're born with a condition, they can maybe pay attention to their training load, or what kind of exercise they're doing, or how far they can push themselves. So then so we covered kind of young adults who are maybe college age. And then after college, when we're thinking about people starting their job and moving on with their life, most of the congenital heart defects may be caught before the age of 30, 35. But what is interesting is I just read a stat that in 50% of counties in the US, the incidence of cardiovascular disease, whether it's a heart attack or even stroke, those numbers are going up among the age group between 35 and 65. Why is that?
I think it's because these chronic diseases of lifestyle are on the rise. We know we're having an epidemic of obesity and diabetes, even like we said, starting at very young ages. And we know that men build plaque from age 18 to 40. So it even starts at age 18. And so having exposure to these risk factors earlier on, it leads to early disease. And women, on the other hand, build plaque after menopause, 50 to 70.
Oh, so men actually start building plaques from the age of 18.
That's correct. Yeah.
Is there a simple test to look at plaques?
There is. And so we do like to assess plaque burden in a younger patient. The best way that we've been using is through ultrasound. So doing ultrasound of the carotid arteries. There's good data for carotid arteries. There's also good data for looking at the aorta and the femoral arteries as well.
But the carotid arteries are the ones that go to the head, right?
Yes.
Okay. And this is a very simple, straightforward test?
Yeah, I actually have my ultrasound here. We can do yours after.
Really? Okay, I'm up for that because, I have been neglecting. This is one thing that, for last 5-6 years, I always think, okay, so I should get my CAC score.
Yeah.
And I always ignore because I'm traveling or something. Yeah. So, but this is so simple that you can actually get it done now.
It's simple. We have handheld ultrasound now that can connect to my phone. And I had the sonographers at work teach me the pretty easy, simple protocol to look at the carotids. And we can use color Doppler and we can get a really good sense of the carotids and you can see plaque in there.
Yeah. But then, when an average person like me, we go to see for our annual checkup, we usually get our blood work and some of the vitals, for example, blood pressure and other stuff. So what are the things everybody should get done after the age of 18? Because you said that many, particularly men, start building plaques from the age of 18. So what are the things that anyone, whenever they're going for any annual health checkup, whether it's here in San Diego or in a rural hospitals or clinic anywhere in the US or anywhere in the world, what should they be checking?
So I'm going to give my belief on this, which is a little bit different probably from what the guidelines in primary care would say. And I think the guidelines are great. We need them, just like we need traffic signals on the road.
Yeah.
But we're also starting to move beyond that and change our mindset about prevention to we should start earlier. And there's a lot of talk in cardiology about shifting upstream to think about the risk factors for cardiovascular disease before any disease has occurred. The old mindset is let's wait until we find disease and then we'll treat aggressively. And so I definitely believe in finding disease early to prevent suffering and to prevent unnecessary death. And so, and like I said, I think a lot of these things, looking for risk and treating it is very low risk in itself with potential for high reward. So I feel comfortable recommending things to my patients that are maybe beyond the guidelines of let's look into this. It's a very inexpensive lab or it's an ultrasound with no radiation and we can be ahead of the ball and prevent risk. So I'll give you what I prefer for my patients is what I call a 360-degree risk assessment. I even think a young person age 30 or in their 20s should have this. My dream is that everybody has this. And you need a 360-degree risk assessment to understand how to manage that patient in terms of the lipids and blood pressure and everything. So the 360-degree risk assessment includes talking about symptoms. So are they having any issues? Usually not. And past medical history, have they had problems in the past already? Do they have known coronary disease? Do they have diabetes? Do they have high cholesterol? Family history. Does someone in their family have an early heart attack? Less than 60? And then we won't get into the labs. So a metabolic panel looking at glucose, which you do a lot of work with, is very important.
It's the fasting glucose
Fasting
to begin with.
And there's also looking at spike ratios is also becoming of more interest in cardiology.
So what is that spike ratio?
There is so we're looking more at some different parameters for glucose. So there's a triglyceride glucose index, and then there's the glucose spike ratio where you look at glucose to A1C
I see.
and see if you're having spikes in the glucose with a normal A1C.
I see.
So
Okay.
the idea is that glucose is an independent predictor for cardiovascular disease, even when controlled for lipid panel. So cardiologists are starting to care more about glucose and diabetes especially. And we're getting into the diabetes drugs and starting to help with management about this.
So what you're saying is even when you think of normal person thinks about heart disease, they think of blood pressure and blood cholesterol and triglyceride. But what you're saying is now even with normal risk or high risk, having high blood glucose increases the risk for cardiac event.
absolutely, yes.
So blood glucose becomes even much more important than managing blood glucose becomes much more important, even more important in preventing cardiovascular disease.
Yes,
Okay.
it does.
So blood glucose is one. Then what else they should be checking?
So we said the metabolic panel, the lipid panel.
Yeah.
I like to get an advanced lipid panel called the NMR, where we're able to look at particle numbers, and which is a different lipid parameter. Rather than counting up the cholesterol on each particle, you look at the number of particles. You can tell if the particles are overloaded or not.
So the cholesterol in our blood is actually in this tiny ball.
Carried in
Particles. Yeah.
exactly.
So the bigger particles are good or bad, or smaller particles?
Overloaded particles are bad.
Okay.
Yeah. So it allows us to get, I say, to evaluate for the hidden risk, because someone we see all the time in clinic, patients who have a pretty run-of-the-mill LDL cholesterol, but maybe they've built early plaque, and you have to ask why and look back at those more advanced lipid parameters. Often you can find the answer there. Maybe the LDL particle number is discordantly high compared to the LDL, or maybe there's a problem with the HDL where the HDL particle number is very low and it's very overloaded. So it's a dysfunctional HDL. So there's different, more advanced parameters we can look at to try to understand what led to this person's risk.
Okay, so let's dial back and you can tell a little bit about what should be the ideal LDL and HDL numbers should be, because there are clinical guidelines. And then we can dive into the particles. What should be the particle number and in different fractions? Yeah.
So I say there's no ideal number anymore. There's no normal value anymore. Even though if you get the labs done, it'll give you a normal range.
Yeah.
It's individualized. So we're getting into individualized and personalized medicine now. And so once I've done the 360-degree risk assessment, which I didn't even finish telling you about.
Oh, yes. I'm sorry.
No, that's okay. This is a part of it. But once I've done the 360-degree risk assessment, we know what to do with the LDL. And I can tell somebody what their LDL goal should be. And so once we put them on a spectrum from bulletproof all the way to very high risk, then we know how to manage them moving forward. If some people are bulletproof, they don't build any plaque, and their set of genes that determine their risk for cardiovascular disease is such that they just have a very low risk, Doesn't mean that lifestyle is not important. That means it's more important in those patients.
Yeah.
But we don't need to treat them. It
Yeah.
means that they're actually going to have a greater benefit from lifestyle management than they would if I gave them a statin. So I'm actually going to do harm by giving them a statin. So I want to determine who's going to benefit from treatment. So the bulletproof, they would not benefit. They benefit from lifestyle. The very high risk benefits from the big gun medications to drive the LDL extremely low.
I see.
Less than 55, for example, is in the guidelines now for very high risk patients who've had multiple heart attacks, for example.
Okay. Yeah.
And so if some in the usual healthy person, we usually say aiming for an LDL less than 100.
Yeah.
And you can say a particle number less than 1,000 because it tends to be, except for in those who have a discordant LDL and LDLP, that the particle number is 10 times the LDL.
I see. Okay, so then let's go back to the 360 assessment.
The 360. So we've got the labs.
Yeah.
And then there's some additional labs that we look at that have been shown to be good predictors of MI. And I say markers of hidden risk.
MI is?
Heart attack.
Yes.
And thank you for reminding me. And you've probably heard about this, high sensitivity CRP.
Yeah.
And I know you've heard about this, but everyone who's listening has heard about the idea of looking at inflammatory risk recently and residual inflammatory risk. So high sensitivity CRP, high sensitivity troponin, which is a marker of irritation in the heart muscle and predictor of heart attack within the next 5 years. Ceramides is a marker of inflammation in the artery wall, specifically, which is a marker of residual risk and potential heart attack risk as well.
So ceramide is one type of fat, right?
Ceramide, yes.
Yeah.
And it comes from the vessel wall specifically.
Okay.
Yes.
Yeah. Okay, sorry, I interrupted.
No, please. You're driving the show here. and then we can do the carotid ultrasound, like I mentioned, in younger patients especially, and in women, we like to use ultrasound first because there's no radiation risk. And then a CT calcium score in patients who are a little bit older where we feel more comfortable exposing to some radiation. It's very, very low radiation. For reference, equal to 1/3 of a mammogram, which women get every year.
Yeah.
So we're talking pretty
Very
low
low.
risk here still. And that allows us to count up all the calcium on the outside of the coronaries, add it together, and create a score.
I see.
And lastly, we can do a polygene risk. So have someone get their gene sequence, 23andMe. We have an app to connect to, and it will create a polygene risk score and divide into categories of risk. And that tends to be helpful in younger patients as well.
Oh. Okay, so I'll remember all of that, and next time when I go to my annual checkup. No, I'm super excited because we know in basic science research that all of these factors count. Your genetic predisposition counts, the inflammation, lipids, and different types of lipids like ceramide that you pointed out, and troponin, high sensitivity CRP. Then there are also many gut metabolite. They're also slowly coming up.
Exactly.
So the exciting thing is if somebody wants, they can actually have a much deeper and thorough understanding of the current heart health. And since heart disease is still the #1 cause for death and disability in the US and also around the world, once you manage your heart health risk, you essentially manage your longevity.
Exactly. And that's why the heart is at the heart of health.
Yeah.
Exactly. Because it is connected to your entire longevity and your lifespan, managing that risk. Yeah, absolutely. Which is why it's so exciting.
So we talked about what the 35-year to 60-year-old or 65-year-old should get checked. Anything specific about those who are above the wiser adults, above 65? I don't want to use the word older because that's also a changing concept, because as people are going to live up to 120. Yeah.
And cardiologists, we are not ageist. We'll replace a valve and put in a stent up to 100. So I think we're I agree, wiser. And age is a construct.
Yeah.
But yes, so we're doing the same risk assessment. Ideally, in the perfect world, in the future of prevention, we've started doing it at a young age, and you do it again and again and continue to follow that risk so that you're informed and you can manage that risk.
Mm-hmm.
But what we're seeing now is usually it's that age in the 50s and 60s where patients start to present and wonder about their risk. You know, they've had a discussion with their primary about their LDL cholesterol. Maybe it's 150. It's over 100, but it's not over 190 where it's a slam dunk to treat it.
Mm-hmm.
And so they're wondering, do I need to do something about this? What does this mean? I feel fine.
Yeah.
And then they come to the cardiologist. So my usual patient population is this next age group.
Mm-hmm.
So I do a lot of this risk assessment in that group.
Mm-hmm.
And the difference probably from doing it at a much younger age is we find more disease.
Mm-hmm.
A lot of times we will find disease and we'll be in the mode of trying to prevent progression and to reverse disease in this age group and prevent a heart attack.
Mm-hmm. So going back, as you are saying all of this, one thing that occurred to me, you might have seen many examples in your practice where somebody comes in, all the usual tests, for example, LDL cholesterol and blood pressure may be okay or normal, but when you do 360-degree assessment, something else quite dangerous pops up.
Mm-hmm.
So have you seen some of the examples, and what are those typical ones?
I saw one this week, actually.
Really?
Yes. So a patient who had a calcium score done for risk assessment. This was a middle-aged woman, very healthy and engaged in her health, feeling well. She had a family history of heart disease, so she was concerned about her risk, and it was on her radar. So she had a calcium score done and it was elevated. Mm-hmm. And she was 55. So in a woman, like we said, that's actually pretty young to have a significant amount of calcium. And she was maybe 70th percentile for calcium at her age and gender. And when we look back at her lipid panels over the years, again, it was pretty run-of-the-mill. So nothing that would raise a red flag and nothing that would explain all the plaque that she had. And so when we looked at the NMR, which was the more advanced lipid panel, we could see that she had a very low HDL particle number and a very high HDL. So overloaded dysfunctional HDL, which we're finding HDL, there's a whole world. We could probably do a whole podcast on HDL and all we're learning about it, but I'll just say hers was dysfunctional. And we think potentially, our hypothesis is that potentially her elevated risk could be from that. And so we managed.
So can you say a little bit about that HDL, the particle size or particle number? Which one was worrisome?
Her particle number was low.
Yeah.
And her HDL itself was on the high side. So HDL, what we've popularized the idea now is that it's what everyone used to call the good cholesterol.
Yeah.
It is good.
Yeah.
But we know that there's kind of an ideal range where we want the HDL. That's kind of what's come out. What we're learning, though, is that you also have to look at the HDL particle number to see if it's going to be functioning well.
Yeah, I see.
And so what we've learned is that you don't want an overly high HDL. You do worse. You don't want an overly low HDL. So you want kind of in that sweet spot, probably 50 to 70 range.
Yeah.
But then you want to look at the HDL particle number and make sure that that's not abnormally low
I see.
as well. So there's a lot that goes into the risk assessment, looking at those numbers. I almost sometimes envision it as like reading the tea leaves of the lipid panel, or in being an investigator and finding where that risk might be coming from. But the importance of finding it is that we can target it. And we have some supplements that we use to raise the particle number, raise the HDL particle number, and lower the LDL particle number. So we were targeting the particle numbers and started her on some supplements to do that.
Yeah. So this is one example where going beyond the regular SDL, LDL number actually helps people to capture something high risk and then start to work on it when they're still feeling well. Because that's something that everybody, including me and few of my friends and family members, they always say that numbers may be abnormal. They say, well, I'm feeling well.
Yes.
And feeling well should not be equal to your heart is doing well, right?
That's the trouble with
Yeah.
cardiovascular disease and coronary artery disease. It's a silent disease, often until very late or too late.
Yeah.
And so I don't want, we do see, working in the hospital, I was on overnight last night, we do see a small number, but people who die who shouldn't have died, that I wish we would have known because we could have made a difference. And maybe they had no problem. They had no idea they had any issue with coronary disease, but they had a cardiac arrest,
Yeah.
Playing pickleball or something. And it's devastating. And I just feel so determined to reach that person decades earlier because we know it's reversible.
Yeah.
So there's so much good to be done.
So I just saw one number that in a year in the US, nearly 1.5 million people get a cardiac event, and 750 to 800,000 people cannot make it, die. What fraction of that 800,000 people who are dying can be preventable? Do you think that anyone who is getting a cardiac event and dying between the age of, say, 40 to 60, most of it is preventable?
I think most of it. Yeah, because most of it is in that age group is going to be coming from coronary artery disease and plaque rupture.
I see.
And I think that with a 360-degree risk assessment, that's where you can make the real difference in it, and that's where the mortality benefit is.
Yeah. So then the question is, okay, so now we know that in the US, nearly 50% of adults have some kind of hypertension, whether it's low, moderate, or they are hypertensive, high blood pressure. And then similarly, I think the last number I saw was, at least in California, nearly 50% of adults are pre-diabetic or diabetic. In the US, I guess nearly 85 or 90 million people are known to be pre-diabetic, and then 35 to 40 million are type 2 diabetic. So it's a pretty big number. So
Yes.
we can almost say that if you take a average 50-year-old, then nearly 50 to 60% of them would have at least 2 to 3 risk factors that will predict a cardiac event in the next 5 years or 10 years.
Yes.
So then, what can they do?
Well-
what is your, because this is kind of, these people are feeling well. They don't, as you say, that they don't have pretty high level of lipids that they have to take statin or something else. Similarly, those with pre-diabetes, they're like, oh, maybe I can work with exercise and losing some weight, which is very difficult to practice on a regular basis. So what do you tell your patients?
Yes. So I think that American Heart Association put out a really nice summary called Life's Simple 8. And this has been studied really well. And it's actually fascinating where they see, and you can look at the graphs of mortality plummeting with the more of these simple 8 that a patient does. Okay. And so the issue is that less than 1% of the study populations actually did all of these health metrics.
What are those 8?
So the 8 are healthy diet, physical activity, avoiding nicotine, healthy sleep, healthy weight and healthy levels of what we've talked about: blood lipids, blood glucose, and blood pressure. So simple 8, but we can delve into some of them a little bit more.
Your favorite ones.
What I tell my patients.
Yes.
So what we'll do is evaluate the labs and we'll work on those together. But what I'll tell every patient, even if they've got really low risk in their labs, is the importance of diet. So we have the best evidence in cardiology and potentially in all of dietary research in terms of dietary content in the Mediterranean diet, because we have a large randomized clinical trial in the PREDIMED trial. And so that trial showed a mortality benefit from Mediterranean diet. So I like to recommend Mediterranean diet for my patients. What does that mean? Lots of fruit and vegetables. I think all healthy diet investigations agree that lots of fruit and vegetables in the diet is positive. That's going to be unrefuted.
All fruits.
I hope.
All types of fruits.
And
Because here is one thing. Recently, I saw an article. What is happening in plant breeding, horticulture, and fruit sciences? We have been selecting sweet fruits so much that we really means. Sometimes when I'm from India, sometimes when I go back to India and I go to a rural market and I pick up a fruit and that has so low level of sugar that I can enjoy all the other flavors and other tastes. But here in many Western countries, the fruits have been selected to have so much simple sugar that it almost feels like I'm getting a sugar bomb. Like, for example, having a bowl of even strawberries and banana. Once I was wearing a continuous glucose monitor and I have a bowl of berries and bananas, my sugar went up.
yes. Well, you are correct. Is that some fruits are better than others?
Yeah.
I start baby steps of eat fruits and vegetables, try to have as much as you can on your table. But dark fruit actually tends to be the best thing for reducing mortality from heart disease and cancer.
Okay, so let's go over the dark fruits.
Dark fruits, so berries, dark cherries, plums, those types of fruits.
Yeah, because they also have flavonoids. Right?
Exactly, the high flavonoid fruit.
High flavonoid fruits. Yeah, so just a disclosure, it's not that fruits are bad. I mean, if I have to choose between a sweetened beverage like a soda and fruit, I would always go for fruits.
Yes.
Let's make that very clear. Yeah.
Yes, it's just, especially if we're talking about a patient with diabetes, we do say, avoid the tropical fruits.
Yeah.
Those tend to have a higher glycemic index and will spike the sugar more. So, but dark fruit is really wonderful for the heart and for prevention of cancer as well.
Yeah.
So, and then other aspects of the Mediterranean diet, we say incorporate 4 tablespoons of olive oil a day. That was what was used in the study. 2 handfuls of nuts. Really, any nuts are good. Probably the least healthy nut is the cashew.
Okay.
And the most healthy is the walnut.
Oh, okay.
So a good snack would be some toasted walnuts and some berries.
Okay, not the salty cashews.
No,
Okay.
no.
To make sure, because, among all the nuts, cashew nuts may be the easily available ones in most stores, and walnuts a little bit, you have to find it.
Yeah, exactly. It's interesting. They don't put it in the prepared nut section.
Yeah.
They often will put it in the produce section or in the baking section.
Yeah.
But I love to get the ones from the baking section and toast them in my own oven.
Yeah.
And they get a little bit crispy and incredible.
Oh, yes, I forgot to mention that about your heart healthy book. So another thing about Liz is I was surprised to see her book in Amazon.com because I was looking, somehow I was searching your name and then that came up. And what I really love about your book is you have recipes that anyone can prepare, and these are not fancy recipes, and these are low cost. Means most of the recipes I was looking at, you can prepare for under $5.
Yes, yes. I'm so glad you noticed that. That's exactly what I wanted. I wanted it to be achievable.
Yeah.
Things, a lot of the recipes are you dump everything into a pot, bring to a boil, and simmer. Or you dump everything into a blender and you make a delicious sauce. It's very simple and exactly no trendy ingredients that you're never going to find somewhere. I didn't want it to be a book that goes on the shelf and collects dust. I wanted it to be out there getting dirty as you're cooking. So, yes.
Yeah, so fruits and vegetables, and then,
Fruits and vegetables, olive oil,
Yeah.
nuts,
Yeah.
2 servings of fish a week, especially salmon.
Yeah.
And those are kind of the main aspects of the Mediterranean diet. Incorporating whole grains is good. Avoiding added carbs, we're finding is actually the most important aspect of a heart healthy diet. Turns out carbs are responsible for a lot of the coronary disease that comes from the diet. We used to think it was all about saturated fat, but we're finding carbs, which goes with our discussion about the importance of glucose.
Yeah.
And so the other aspects that I tell patients, it turns out that, so we've gone back and forth on eggs. Probably trying to avoid eggs is the best evidence now that in a large retrospective study, it does increase the mortality, and that's the egg yolk.
Yeah. So egg white is okay.
Egg white is okay.
Okay.
Yes. And I think people start to lose a little bit of trust in our recommendations about diet because it does change. Eggs is a great example of how we've gone back and forth, and it's been in the lay press a lot of eggs are okay now, eggs are not okay now. But I think, we're putting together lots of different types of data, retrospective, prospective, clinical trials, small trials, and trying to always reassess and constantly come up with the best recommendations. And so we do our best.
Yeah, but it's very simple. Like, for example, a few years ago, I think I was looking up how much cholesterol our body needs because some of the research that I do relates to cholesterol metabolism. And then what caught my eye was the yolk from a single egg can supply up to 50% or even more than 50% of our daily need for cholesterol. So that means if someone is having 2 eggs, they're actually getting all their cholesterol need of the day from those 2 eggs. And that's just 2 eggs. Means you go to have a good healthy breakfast from a restaurant, and those usually the omelette is 2 or 3 eggs.
Yes.
And scrambled egg, you have no idea how much yolk went into that. And then when you are having any pastry, any cake or anything that also has eggs.
Yes.
And there, no one is actually separating egg yolk from egg white. So just knowing that one single egg yolk can supply 50% of my cholesterol, that made me convinced that I should never, ever eat more than 1 egg yolk in a day.
I think that's a really great analysis of it. It's eating a lot where you run into problems. So eating 1 here and there is totally fine, or eating 2 here and there, I think. But trying to avoid as much as possible, and certainly avoiding eating, some people will eat multiple eggs a day.
Yeah.
And it's understandable because in the past we've said that's fine, but from what we know now, avoiding would be best.
Yeah.
And similarly, it turns out cheese is actually okay for the heart now because of the bacteria in cheese. But avoiding, cream and butter type of things.
Yeah.
Avoiding red meat, which increases MI by 15%. But
yeah, so when it comes to cheese, we have to clarify a few things. You said the bacteria in the fermented cheese does many good things for the heart.
yes.
I come from India, and in India, cheese or cottage cheese means very different thing. It doesn't actually have any bacteria. We boil the heck out of it.
That's a great distinction.
Yeah.
It's the actual presence of the bacteria and the fermented aspect of it that is
Yeah.
beneficial.
Yeah.
Similar to yogurt. Yogurt also is good for the heart. And we saw that in the DASH studies that actually yogurt lowered blood pressure.
So DAS is low sodium, which
Yes, it's the diet that that's been tested for hypertension. And it does involve low sodium diet. But they saw that the group that didn't eat yogurt didn't have as much of a blood pressure reduction with that diet.
so having yogurt ideally with live bacteria, because that microbiome is going to give us some benefit.
Yes.
Will have the best benefit for lowering blood pressure.
Yes.
Okay.
And it brings in, I think you brought up about some new markers of cardiac risk like TMAO.
Yeah.
And that probably plays in with why there's a benefit to yogurt and cheese, is this interaction with the gut bacteria, and the gut bacteria can create some end products that have an independent mortality predictor for cardiovascular disease. So like you mentioned before, we're starting to understand how gut health interplays with cardiovascular health as well.
Okay, so we have gone through how many out of 8?
There's so much to dig into with all of them.
No, I guess
This course is my favorite.
Yeah, because diet is something. I heard something that every time we eat something, either we are fighting or favoring a disease. So diet as a thing that's the most frequent way we interact with nature. So when you think about nature versus nurture, or what is in our genetics versus how we interact with the nature, diet is something that everybody interacts with. Whatever stress levels you are in, or whatever comfort zone you are in, or how much ever you have slept or not slept, every day we are going to, almost every day we are going to eat. And every time we eat, we are doing a favor to our health, or we are doing some harm to our health. So
exactly, it's medicine that you're putting in your body every day, and I do like to think of it that way. When you're reaching for a snack, think, why don't I put something that's positive for my body in? And having that mindset, trying to be a more empowering mindset too. Not, well, I can't eat that, that's a bad food.
Yeah.
But what can I put in that tastes good and that is positive for me, that's almost like the best medicine we have in the whole world. Back what I was fascinated with in medical ethnobotany, that we can treat our own bodies with what we put in every day, is pretty cool.
Yeah. So let's touch on that one, that plants as medicine. We talked about food, Mediterranean diet, whole grain, and all that stuff. But at the same time, there are many supplements that largely come from plants. Are there certain supplements that you recommend to your patients for managing their blood sugar, blood pressure, or blood cholesterol?
There are. And so there's pretty good data on some supplements. And supplements tend to get a very bad rap because 95% of them will have not as much active ingredient in it as the bottle says. So it's much weaker, and maybe it doesn't work as well because that supplement industry is not regulated in the same way that pharmaceuticals are.
Yeah.
So for those of us who have a real interest in this and want to develop expertise in it, we look at outside labs that test different supplement brands and how much active ingredient is in it. So we can advise our patient, these brands have the highest amount. And then reviewing the data and the mechanism behind these, often which is published in some of the best scientific journals like Nature. And we're able to use these and in a very safe and inexpensive way. So that's the prelude. Not widely popular in cardiology, but in integrative medicine, which I also am interested in, we do use them a lot and study them a lot. And it's all evidence-based. It's the best evidence that we have anyway. And so you asked me which ones, and I just have to give this long preamble disclosure. But so we do use I'll name a few.
Yeah.
And then maybe you can ask me about ones that you're specifically interested in.
Yeah.
So we use red yeast rice, which is actually just a statin. So it is a statin. So if a patient has statin side effects, I would not necessarily reach for yet red yeast rice. We could try it because it's reasonable to try a couple different statins to see if they're tolerated. But it is a statin. It has lovastatin in it. We use berberine, which is it's actually an ancient Chinese herb. Been used in Chinese medicine to treat GI illnesses for a long time. We use berberine, citrus bergamot, which is an Italian citrus, and we use magnolia bark, and then we use, we use a few that have zero side effects and are very safe, I say, for anyone probably to take. We use pantothene, which is vitamin B5, probiotic, a certain probiotic, and that has bifidobacterium in it, and artichoke.
Artichoke. Yeah.
Artichoke,
Yeah.
yes. That trio does lower cholesterol. B5 is a cofactor for the enzymes in bacteria. The probiotic is obviously the bacteria, and the artichoke is a prebiotic. So they're all kind of targeting the gut and gut metabolism to reduce cholesterol. So those are some of the supplements that we commonly use to manage LDL and the particles, as we can use some of them target more of the particles, some of them target LDL itself.
So we always come back to this point that there are a lot of people who have a LDL cholesterol level which is not high enough to start statin or any other cholesterol lowering drug. So these supplements may be some of the ones that, but then you also brought up this point that since these are not regulated, it's really hard to find reliable ones. So are there any other certifying agency? Like, for example, when I go, there are labels that says these are certified for athletes, for example. There is a body that certifies certain supplements for athletes so that they are not inadvertently consuming something that is banned substance. So is there anything that people right now can use as a reference?
So what we're using is consumerlabs.com. It's an outside lab that tests the content of
Consumerlab.com?
consumerlabs.com. I'm not affiliated with them.
Okay.
But I find it very helpful because they tell us the brands. They will test all the brands and they'll say how much lovastatin is in each red yeast rice.
I see.
And we can then pick the top few and say these are reasonable brands, and say I would avoid the one from Costco, for example. It says it has 1,200 milligrams and it actually has 200.
Yeah.
So it's very helpful to do it that way. And so knowing that 95% are trash, 5% are good. That's why it's so hard to study and they get such a bad rap. But I'm doing a lot of work trying to study our success with lipid lowering with these supplements in the integrative clinic, where everyone who practices there has such a special interest in supplements and studying the research and getting to know which ones have a highest efficacy and which ones don't. So studying it in that specific environment allows us to know which ones will be useful. And again, you always reassess and say, if someone doesn't respond, I don't say stay on it forever. I say, let's take that off. You didn't respond to that.
No, that's true, because even for medications, not everybody will respond to the same medication to the same extent. So that's why people doctors do dose adjustment or even different medication. So I guess that should also be kept in mind for supplements.
Yes.
Because not the same supplement will not have the same effect in multiple people.
Exactly.
So it has to be very personalized.
Yeah. We usually give it 2 months. We recheck labs and see the patient back and decide whether it's working and useful or not.
So some of the supplements that you mentioned, the reduced rise is lovastatin, so that's similar to statin. But then let's go to the next one, berberine. Suppose say you take a random or a patient who may be more sensitive to statin, so that's why this person doesn't want to be on statin. Can the person, hypothetically or in your experience, have you found people responding to berberine in the same magnitude as they would respond to a low dose statin?
Yeah,
Yeah?
I have seen that. Yes, we do see, and this is in the.
Do you have any case report or anything? Because there are not too many large randomized control trial, but all of these start with case reports and small studies.
Yes, I actually just brought a case report to AHA where I talked about this. We had a patient with heterozygous familial hypercholesterolemia, so someone who's had very high cholesterol for their whole life and was already on Evkeeza, which is an advanced injectable lipid-lowering medicine, lowers LDL about 50%, targeting ANGPTL3, was already on max tolerated statin. So it was already on all the guideline-directed, and again, I'm still following the guidelines. I'm still a cardiologist. I'm following the AHA ACC guidelines for best management. I always want to give my patient the gold standard. But this patient was already on all the gold standard, and the LDL was still over 200. It was still high.
Yeah.
And so that was a really good point to bring in, well, we have some other tools in the toolbox. And so we used berberine on her, and we had over a 40% reduction in her LDL.
40%, that's a pretty big number.
Yeah. With berberine on top of all these other therapies she was on.
Oh, I see.
So it was an exciting case, and sometimes we see that. I think the average reduction is about 30% in LDL, and it reduces triglycerides even more than that, the 40-45% range.
And how long this person was on berberine before you saw a reduction?
2 months.
2 months. Okay. And how much berberine? I'm just curious because
we use 1,000 milligrams, which is in the brand. We recommend 2 tablets once a day.
Okay. Yeah. No, it's kind of interesting that some people may not respond. The same thing goes, as you mentioned, this person had already gone through a lot of recommended medication. So the point is to develop a relationship with the physician so that, for example, you have gone through the case, all the medications this person has gone through, because one thing is, many of us who are, a healthy person, I saw this somewhere, a healthy person is an ignorant person. If you don't know your your health stats, then you'd be happy.
Yeah. It's better to be empowered with the knowledge.
Yeah.
That's what I say. And it's funny because in clinic, I go and I do the 360-degree risk assessment, and I find things, and people come back and they say, I'm so scared, I'm so stressed. And I say, no, this is not meant for that at all.
Yeah.
Maybe the advanced heart failure clinic is meant for that. And they do so much good, but it's on the back end. I'm on the front end. I have the luxury. I get to be ahead of the ball.
Yeah.
And I find that to be so exciting. I said, no, this is supposed to be exciting and empowering because we found something way ahead and it's reversible.
Yeah.
So it's meant to be positive.
Yeah. So it's almost like, when you're driving a car, if you know the weakest part of your car, then you can actually drive it to the moon. I mean, when I say drive it to the moon, it's 250,000 miles. That's the distance. But if you don't know, then you'll be stuck somewhere.
Yeah.
You'll have a breakdown. So coming back to, again, what a person can do, an average person starting from, say, adulthood at the age of 18 onwards, do you recommend everybody should go get their annual health checkup done every single year? Because I hear 2 kinds of opinion, even from physicians. Some say, no, you don't have to come every year. Come once in a few years. nothing will go wrong in 2 to 3 years, versus another camp that says, no, you should actually go because it's not something going wrong or going out of the reference range, but what is your trend? For example, someone may be trending, fasting blood glucose may be 75 to 85 for 10 years. And all of a sudden it goes to 95.
Mm-hmm.
It's still under the safe range. But within a year, going from 75, 85 to 95 is a big jump.
Yes.
So where do you stand?
I stand in the camp of we should be we should be seeing the doctor once a year. I think we should be empowered with this knowledge, and we should see that jump in glucose. We should see, in women when they go through menopause, they lose half of their LDL receptors.
Oh, I didn't know that.
Therefore, LDL rises, and that's when plaque starts to build. So we should be seeing these changes and be empowered with that knowledge to make a difference early on, because we know the earlier the better. That's what the studies are showing. We need a decade of low cholesterol to start to reverse plaque. So earlier the better. So I believe, yes, that I like to see my patients back and check in. And I think for prevention, and maybe this isn't now, maybe it's in the future, maybe the medical system's not ready for this for everyone, but I believe that having a visit at 18 and being followed through adulthood to check in for prevention is the future of preserving health rather than treating disease.
Thank you. No, that's a really nice ending, that preserving health is way much more important than treating disease, because to be frank, once somebody has one heart attack, then that person's total performance, emotional, intellectual, physical performance takes a hit. Actually, the self-esteem, the self-confidence takes a hit. So why to go there and start to be healthy from day one?
Yes. And why go through that suffering ever when we could have prevented that entirely?
Yeah. Thank you so much. And I'm sure we glossed over many topics. Maybe we can go back again, and then have a few more episodes with your insights and wisdom.
I would love that. Thank you for having me.
Thank you.
Thanks again for listening to this episode of Performance Around the Clock. I'm your host, Professor Satchin Panda. I hope you learned something new and found this episode exciting. If you did so, please leave us a comment. If you like the science that we discussed and would like to make a donation to research in my lab at the Salk Institute, you can do so by going to panda.salk.edu/giving. Thank you again for listening, and I'll see you next time.